So the next subject is, our school agers. Who in here has a school ager? Not too many? Oh, we got one over here? Okay. School agers, the thing I want you to think about our school agers, and then we're going to go to our teenagers, but our school agers, the thing that comes to mind mostly is their cognitive ability. So let's take a little journey to here. School age is 6 to 12 years. Physical period is really latent. During this time, I will tell you, can I have you put in the margin this one piece of thought? You probably want to know how much does a child averagely gain every year in terms of their height. Just put to the margin at 3 years and all the way through to adolescence. So it's all the way through toddler, preschool, and school age. They typically will gain on the average 2.5 inches every year. Okay? Some people say 2 to 3 inches, but I usually say about 2.5 inches a year average. Guess how much weight they put on throughout school age? 5 to 7 pounds. So this is a latency period. Not a lot's going on, but they're still growing and they're still gaining. And I believe in your notes on page, just to reiterate, if you wanted to have this in another section, it's going to be, let me see if I can just identify it for you. Yes, it's on page 56. So you'll see under physical exam, when we talk about it, that kind of gives it to you 1A, 1 and 2. Can you see that there under the physical? So it kind of reiterates it there. So it's page 55. And cognitive conceptual period, this is, we're going to talk about it. I have a great little story to share with you. And psychosocial, they're industrious and trying to please adult figures. Again, periodicity says bring all that good subjective, objective data forward. And we're going to talk about the interview. Well, kids, for the most part, like to look at figures and diagrams. You can guess what? We're worried about weight. Let them look at their weight plots on their measures. Let them see how they're plotted out. They're trying to be brave. They're trying to be industrious and so forth. And when you do your physical exam, you think about, again, as we just mentioned, this is key, that 5 to 7 pounds, 2 to 3 inches, pretty much a latency period, because they still continue to grow, even though it's not as a great amount. Some girls, if you looked at this peak height velocity at age 11 to 12, if you looked at a class of sixth graders, you look at the girls, they're usually what? Much taller than the boys. So they were go through their peak height velocity much earlier. Usually, and just before we get into adolescence, do you all realize that girls that go through their growth spurt, by the time they go through their growth spurt, menarche has usually occurred. So that will tell you how tall they're going to be, okay? We do height, weight, and BMIs. We're very tuned into BMI for kids at this age because of what? When did we start doing BMIs, by the way? We started at 2 years of age. So here we are, we're still plotting their BMIs, and we're concerned because our country, does anybody know what the percentages of children that are obese? You're going to be blown away. It's 34% is the latest data. 34%. So we know that's a huge concern. Vital signs, we continue each visit, physical exam, head to toe, visual acuity, whereas a 5-year-old should be what? 20/30? By the time they're school agers, 20/20. Permanent teeth erupt. 6 years is a real key time, right? Remember that? 6 years? Now, I don't think, this is just a picture, in your material there telling you it's pretty hard to read, but I kind of like the one earlier that kind of went over the primary and the others. Breast development, scoliosis screening. Now, let's think about this. Breast development can occur during the school age period. We are going to talk about how that fits in with regards to all the changes with adolescence in a few moments. Scoliosis screening occurs around 9 years. Why do you want to do scoliosis screening? You want to pick up a child that maybe has scoliosis so that if you brace them, they say, it is suggested, that if you brace a child that has this idiopathic scoliosis, 85% chance that you're going to really straighten out that spine without any other need for intervention. So it's really a benefit. Motor skills, well-developed muscle and strength increases, hand dominance is noted. And then for all of your developmental monitoring, let's think about the cognitive aspect. Industry versus inferiority. Jean Piaget says this is the time of concrete thinking, cognitive tasks, acquiring new knowledge. Language becomes fluid and descriptive. Thought processes expand. Way I want you to think about is, let's look at a couple of the C's. So this is the C period. Think about this. Capable, concept of conservation, classify, concepts of time and money. Are y'all getting a feel for concrete, operational, logistical operations? Cause and effect, concept of space, and capable of deductive reasoning. Now, I'm going to read you a story because this is classic for school agers. And I have to read it because I always mess it up every time, and I don't want to miss the punchline. This is where it says here, capable of deductive reasoning. Okay, 2 young boys walked into a pharmacy one day and picked out a box of Tampax and proceeded to the checkout counter. The man at the counter asked the older boy, "Son, how old are you?" 8, the boy replied. The man continued, "Do you know what these are used for?" The boy replied, "Not exactly, but they aren't for me. They are for my brother. He's 4. We saw on TV that if you use these, you will be able to swim and ride a bike. And he can't do either one yet." Is that not typical school age? And you know, you as a parent of a school age, you go to the store, you know, that's how these marketers do it. They got everything at the end caps as you're checking out, or some kind of, or they've been watching TV and they come running in, Mom, we got to get this. That's what this is. So everything is logical to them. Does that make sense to you? So I want you to walk away. When you get your school ager questions, usually it's going to be about how they think, more so. Psychosocial development, mark expansion, self-esteem, socialization, responsibility. These are kids that are engaged in things outside the home, through school, participating in activities such as sports and so forth. So anticipatory guidance is a time that you want to respect the fact that television programming and internet activity should be monitored. Expect lying, confront child in a positive way. So that's something for school agers. I didn't ask you, but when do you expect to see stealing, innocent stealing, for the first time? Usually that's in the preschool period. Do you remember we talked about causation initiates? That's really key. So if you're a little child, because I know you all who are parents have been there or you're going to be there, when your little child picks up a package of gum and sneaks out the store with you, what do? You got to make a big deal about it, right? Causation initiates. Bring them back, get the manager. You talk about how important it was to bring it back to the store because it didn't belong to you. They're not going to take them off to jail, but you know what I'm talking about. It's making the point, okay? Now remember we used to have the good old, remember the pyramid, which was kind of awesome, huge, lots of information. Now they're doing what? My Plate. So you want to talk about portion control, avoiding junk food. Remember, they may appear to put on weight as their linear growth stabilizes. So if you're only gaining 2.5 inches a year, but you're putting on 5 to 7 pounds a year, that's why these little school agers look a little bit more, they're putting on more subcutaneous tissue, so you want them to be more active. We also know dental health. This is a time of sealants and flossing. All the injury prevention things that are important, such as risk behaviors. And it's been really important to think about cigarette, drug, alcohol use, and so forth. Another little sidebar, if I could just give you, it's a really good free publication, and you Pete's folks may know about this, but what brought to mind was this injury prevention. There's a publication called Pediatric News, and if you Google it and sign up for it, you can get a great little, it's kind of like these smart briefs that you get for AANP and so forth, but Pediatric News is really good. The reason it brought to mind here is there was a great article in there not too long ago where they had studied doing the big talks on risk behaviors with kids is not as good as doing reinforcement over time, and that makes sense. So every time you get an opportunity, you see somebody smoking, you talk about the negative effects, so that reinforces it, and so forth, drug use and so on and so forth. Now, sexuality, very important that, they're very curious about bodily changes. Some of their friends are what? Going through the changes much earlier. So you want to make sure that you prepare them for all that information that they need and reinforce that. Sleep should be very consistent. Nightmares decrease. If you have a school ager that has poor adjustment to school, not working to their ability, frequently ill, need to stay home from school, lacks social interaction or peer problems. If you have an older school age child that reverts to being dependent, shy, passive role, using illness to avoid responsibility. Most kids like to go to school. They like to be with their friends. If you ask a school ager, who's your best friend this week? They almost always can tell you who their best friend is. It may change, but they always have somebody. If they're disinterested in extracurricular activities or they have destructive behavior, you guys see how that works. So there's 3 topics we want to consider during this period of time. One is obesity, child abuse and neglect, and ADHD. So obesity, well, we talked about the 34%. We know it's too many calories, low energy use. It may be, in children can be mild, moderate, or morbid. We know there's many reasons for it. It could be an organic reason, such as, and I didn't go into a lot of the genetic conditions like, there's one called Prader-Willi. Prader-Willi, these kids are pretty hefty, and they have an insatiable appetite. As a matter of fact, I have a little kid that he would leave his house at night where they would lock up the food and go into the neighbor's house and go into their house. I mean, they just, you have situations where there's an organic reason for it. But often it's relative inactivity, use food for emotional comfort, control mechanisms. Again, it could be a genetic or physical condition. There's that Prader-Willi syndrome as an example, endocrine disease. Also medication-induced obesity. There are a lot of medications like, what would be like anticonvulsants, antipsychotics for sure. A lot of your steroids, can make you encourage, more eating and so forth. Diagnostic studies, well, pretty much, monitoring variables such as BMI, height, weight. Management, pretty much, it's a family affair. Now, what do you do culturally when you have a special culture that looks at the robust child as being the healthy child? Then you've got that aspect to work with. So trying to get them to be nutritionally sound is very important, working with the family, nutritional planning. Please do not use the word diet with kids. If you tell them they got to go on a diet, you may throw them into an eating disorder, especially, late school age kids, early adolescents. So you want to make sure that nutritional planning, using my plate, portion control, being more active, all those things are important. Now, child abuse and neglect, pretty much commission or committing a crime like a physical, sexual, emotional act on a child or omitting something that they need. All states require us, we are what? Mandatory reporters, okay? So that you do know that. Pretty much, let me go to this, think about this. If they were going to ask you a question, they're going to look at signs and symptoms, things in your assessment, like they come to you and their history is vague. I know you've had those folks that you've had such a hard time getting the history out of them. Not compatible with the injury, delay seeking care. Physical needs don't look like they're being met, developmental delays, and there's something quirky about the child-parent interaction. You always want to think about, is it an accident or underlying disease? Like, what would be one that we talked about earlier that had blue sclera? Osteogenesis imperfecta. So they usually have more fragile bones. Because, so you want to think about, is there some other condition that may cause, this to occur? Homeopathic cultural practices like cupping and coining and things like that can also be considered. But again, that's working with the culture. Binding, Asian families sometimes bind feet so as to make them tiny and small. I mean, you've seen all kinds of things that can occur. Physical exam, do a thorough physical exam. There's your coagulopathies or osteogenesis imperfecta, doing a home assessment, laboratory radiological examination, educating and working with, those that are high risk, parents, anticipatory guidance to avoid stress. Think about usually, again, young adolescent mothers, they don't always have the best role models sometimes in their family situation. So those families you could best work with. And of course, for mandatory reporters. Now, attention deficit. This is a syndrome of either hyperactivity, inattentive, impulsive type. We, again, are going to rely on the DSM-4 criteria. And you could see combinations of this, and it seems like we know much more about it. We start recognizing it more closely. Some of the things you want to think about is in the criteria to diagnose a child. They usually have to have symptoms present before the age of 7, lasting at least 6 months, and you want to see that it interferes with at least 2 arenas, such as being at home and in school and maybe even at play. So when you think about, oftentimes the teacher will be asked to fill out forms on the child. And we're going to talk about the questionnaires. Epidemiologically, boys are considered to be at a higher rate than females. There's wide variation, diagnostic criteria. Predisposing could be biological, environmental influences, psychological, psychosocial influences. One of the things that they are looking at nowadays is, believe it or not, secondhand smoke in utero. So if you have a child who's in a family of smokers, and while the mother was pregnant and beyond, they're looking at, because when I graduated with my nurse practitioner, my PNP, the theory back then was birth trauma. They've gone through TV, they've gone through looking at sugar. I mean, you just got so many different reasons. We really don't know exactly what it is. But we do know that there has to be 6 symptoms of inattention, hyperactivity, impulsivity, and you've got a little chart there that will show you some of the things. Now let's think about this. If you have a child that has difficulty concentrating long enough to complete a task, I still think about this little fella that I had. I had a foster care child that they labeled him ADHD. Now, he had never been formally labeled. And I know you all have patients that come into your practice and they'll say, I think I need to go on a stimulant. You know, I have a lot of college students that want to do that. I know you know where I'm going with that. And so I always tell them you have to be formally evaluated. And it's not something you just take occasionally. If you really need the medicine, you got to take it all the time. But I had this little fella, again, another foster care child, who they labeled him ADHD, very pleasant, very cooperative, sweet little fellow. Well, guess what? He just needed a hearing aid and new glasses, and he perked up. He could concentrate because he had his abilities back. So we don't always want to think about it. So you've got to think about what else could it be. So we want to also think about there could be some comorbid findings. Learning disabilities, psychiatric, like anxiety, depression, ODD. Okay? What's not up here is bipolar. We do know that if we have a child that also has bipolar disease and you put them on a stimulant can make their bipolar mania worse. So a lot of times, starting when we talk about treating, sometimes other comorbid conditions kind of come out, rear their head, and then that tells you a little bit more about it. There's your sensory impairment. The child with hearing and vision, psychiatric disorder, maybe they're in a situation where they're being asked to do things that, remember the kid that's 5, but he looks like he's the size of a 10, 11-year-old, and maybe he's being asked to do more than he's capable of, okay? Situational anxiety. So we've got a lot of things that can contribute to this. We also know that it's important to how we're going to manage them. Structured environment, operant conditioning techniques. Now, I always think about, I know you've seen the show Hoarders. Can you imagine a child with ADHD living in a house like that? Can't imagine, because where I'm going with this, that's extreme, as you guys know. But children who have attention deficit truly have been diagnosed with it, need a special space that they can call their own, that's uncluttered, where they can put their book bag away, do their homework undistracted, and that all ties into a structured environment. Parenting classes with operant conditioning techniques. When I lived in Atlanta and I worked, I know we're getting ready to do adolescents, but I worked with, and the Pete's people may know him, I worked with Dr. Ed Gottlieb. He wrote the book Practicing Adolescent Medicine for the American Academy of Pediatrics. He was a fabulous doctor. Really appreciated nurse practitioners, had a very interdisciplinary practice. But what we used to do is we would refer our kids who were teenagers, get ready to go to college, to an ADHD life coach for a couple of sessions so they can anticipate with them what to expect when they go to college, and they're going to be on their own, and things are going to come their way, and what kind of decisions are you going to make. There's also a course, pharmacological management, with the use of stimulants. And this is a lot of information on here, but let's look at your notes in your book, okay? Let's take a look at your notes. When you think about managing with stimulants, we want to think about, first, always start low and go slow. So typically, You want to think about usually whatever stimulant you start them on, and if I could just tell you, there's a lot of different stimulants, as you know. On the bottom there, pharmacological management, you'll see you got your methylphenidates, such as your Ritalin, Concerta, Metadate, Focalin. You got your amphetamines, your Adderall, and your Adderall XR. Again, here's a little history. Ritalin came out in 1962. And if you ever go back and study it, it's a great medication if it's used appropriately. It really works well. And then, of course, they came out with all these other medications. But the thing is, you want to start very low, go slow, and start with the smallest amount that you need. Typically, as it says in your notes, usual dose about a 0.3 to 0.7 milligram per kilogram, which basically comes out to about a 2.5 to 5 milligram per week. And you have them come back in about 2-week intervals till you figure out with them whether or not the symptoms of not being focused and being able to do their work and so forth has started to be resolved. You also want to think about, is it short-acting? Is the medication you're putting them on short-acting or long-acting? Well, short-acting, they're going to probably have to be what? Redosed every 4 hours. Or if it's long-acting, you want to think about the medication, it's prepared in a way that you don't want to make sure that you don't chew it, and it's applied a certain way. You all have heard of the Daytrana patch. Have you heard of the new Daytrana patch? The Daytrana patch. See, they're coming up with, all these stimulants have a street value, right? So they're coming up with ways that little Johnny can't give his medicine to somebody else. And think about this patch. They came up with a patch where the stimulant's in a patch, so you put it on the hip, and it's absorbed through the vasculature. And if Johnny decided to take it off and put it on his friend Sam, it shuts down. It doesn't release any more of the medication. So they're coming up with all kinds of neat ways to deliver stuff. What are the top 2 side effects that you have with ADHD? There's top 2. There's several. One of them is, what was it, appetite? Loss of appetite. They don't want to eat. Another one is insomnia. So if you think about ways that they're coming up with, if a Daytrana patch lasts 17 hours, if the mother, as an example, decides to wake Johnny up and put the patch on him, it doesn't kick into gear for about 30 minutes. So Johnny can get up and eat breakfast, get his day going. You see what I'm saying? And then it'll last him throughout most of the day that he's having to use his mind and his behavior and so forth. So you see how that kind of works together? Okay. I'm going to allow you to continue to read that when you study, just to reinforce what you know about stimulants. Let's see. Pretty much, I think that's what I want you to think about. So those are the topics under school age. Mainly it has to do with what? Cognition.